Hello, this is Annette Rebel, and here is part 2 of our education series in anesthesia for geriatric patients. This presentation will focus on postoperative delirium prevention. The US population is aging. We will see more and more challenging aging patients for more and more complex or urgent surgical procedures. We will also encounter more of geriatric patients in the non-surgical anesthesia care areas, as it is the chronic pain clinic or the intensive care unit. As you can see here in the graph, where we are right now, probably in the middle between 2000 and 2025, and we anticipate that by 2050, more than 20% of the US population will be older than 65 years old. If you plan on practicing in Florida, also here there's probably a little bit of more skewed accumulation of elderly patients. Also, it is projected that by 2034, the percentage of patients, US citizens above 65 will be higher than the percentage of children under 18. Why should we pay attention to the age of our patients? What makes patients who are older, geriatric patients, unique and special? What makes them more vulnerable? So one reason is, as you get older, there will be more coexisting morbidities: hypertension, advanced coronary artery disease, advanced cardiac disease, valvular dysfunction, congestive heart failure, pulmonary disease, COPD, emphysema, advanced renal dysfunction, and also keep in mind diabetes also, as insulin resistance is becoming more frequent as you get older. As you in this graph is shown, around age 71 to 80, here there's the highest peak you see in a lot of those comorbidities. Looking at perioperative outcomes, we have identified that frailty, physical impairments, comorbidities, and disability, difficulty in communication, either related to cognitive impairment or physical impairment, all those three elements, as either singly or overlapping, does increase your risk for perioperative complications. So the outline of this presentation is here. We really want to narrow it down on one specific area. In a previous presentation, I have summarized our perioperative concerns when we take care of elderly patients in the operating room or for non-surgical procedures. In this presentation, we will focus on what actions or interventions, system changes of our healthcare system may have a positive impact on the development of postoperative delirium. Postoperative cognitive decline is a major source for adverse outcomes after surgery. It relates to increased hospital length of stay, therefore higher costs, higher rates of postoperative skilled nursing care needs, institutionalization, and also a higher risk of readmission. As our patient collective will get older and we will have a higher rate of patients at risk, we anesthesiologists need to be knowledgeable about risk factors and strategies where our actions can prevent or minimize the impact of these complications. Therefore, in this presentation, we will review the very recently published joint census statement of the American Society of Enhanced Recovery and Perioperative Quality. It reflects the opinion of the American College of Surgeons and the American Geriatric Society. So first, let's go through some definitions. Postoperative delirium is an acute alteration in mental status involving changes in cognition, attention, and levels of consciousness occurring after surgery. It may present as a hypoactive form or as a hyperactive form, think agitation, or also can present as a mixed picture. Postoperative delirium is reported to occur in 10 to 50% of older patients postoperatively. Huge variability in the incidence relates to some surgeries are at higher risk than others. Unscreened, it may be easily missed, especially if it presents as a hypoactive, withdrawn form. Postoperative delirium is a very strong indicator for prolonged cognitive impairment after surgery. Since we're going through the joint consensus statement, let me just go through the methodology, how this statement was generated. The Perioperative Quality Initiative is an international, multidisciplinary, non-profit organization. And they organize regular conferences by assembling international experts with the aim to develop consensus-based recommendations in perioperative medicine. So this statement summarizes the findings of the POQI-6. So at end of November, beginning of December 2018, the meeting was called with the aim to develop consensus statements addressing the postoperative delirium prevention in high-risk older patients. The expert group identified 163 studies via PubMed search from 1966 to October 2018 to address these questions. They were working in 3 groups, but the working questions for that meeting were: what are the baseline and precipitating risk factors for postoperative delirium? What are the best screening methods for predicting postoperative delirium? As a side question, what methodological considerations and best tools for screening are available? And then probably most importantly, what can be done in identified patients to reduce the risk? In addition, also, the consensus meeting discussed what are the high priority research questions which need to be addressed in the future. So here are the recommendations from this expert meeting. Let's first focus on the patients at risk for postoperative delirium. The first recommendation was that hospitals and healthcare systems need to develop processes to reduce incidence and consequences of postoperative delirium through an iterative, multidisciplinary quality improvement process. The expert felt very strong about this recommendation, but it's based on weak evidence that this is beneficial, which means that basically that's the expert opinion. But due to the importance and relevance of postoperative cognitive dysfunction and delirium, our responsibility to patients and society mandates that we, system and providers, need to come up with a systematic approach and process towards this problem. All perioperative disciplines should be involved and adopt a patient-centered pathway, since we believe that 40%, give or take, of postoperative delirium could have been prevented. The next recommendation for patients at risk for postoperative delirium also the experts felt pretty strongly about, saying that healthcare providers need to identify surgical patients at risk for postoperative delirium. Several studies have published conditions and predisposing factors increasing the risk for postoperative delirium. So here in this table, there's a summary of all predisposing factors for postoperative delirium as they have been identified. Patients with lower cognitive and physical reserve are at risk since they have a decreased capacity to compensate for surgical and perioperative stress. Some of those conditions should have been identified during the regular preoperative assessment. But cognitive or functional impairment, frailty, and malnutrition are not routinely and objectively assessed. So here are the action items, I think, where our specialty can contribute, and also here are the challenges. So there are some potential risk factors which we can modify preoperatively as soon as we identify them. There should be a formalized preoperative optimization if there's an area where our patient is not optimal. And a process should be in place to make things better. And the areas which are obvious, but nutrition, not only nutrition counseling, but also checking and following up that our patient is getting better and is optimal to undergo surgical stress. Physical activity, also here, this can be done pre-surgery by making patients aware of and then building up the strength. Not only for elderly patients, but I think for all our cohort, also here, there's very easy to modify and to decrease your risk for perioperative complication is smoking cessation and counseling towards that. As part of the perioperative team, we also need to have a discussion about the type of surgery and the medication exposure our patient is already exposed to. With our surgical colleague, what is the best surgical approach? Open versus minimally invasive surgeries. It will modify your perioperative stress. Are there non-surgical or interventional options also relating to less perioperative stress? And when it comes to medication exposure, a lot of our patients and a lot of our healthcare providers are not necessarily aware of what a patient is all taking. So there needs to be a medication review. What has been described as polypharmacy. How many medications with sometimes conflicting goals a patient is taken. So here is a list of all the identified precipitating factors for postoperative delirium. As it is split up into intraoperative, postoperative issues and their medication exposure, some of them are not within our control. For example, a lot of the surgical aspects we cannot control or influence, like surgical complexity, approach, duration, or the need for cardiopulmonary bypass. But blood pressure management, anesthetic depth, and glucose levels, we can control and we can do better. Medication. It is recommended to stay away from medications with anticholinergic effects. Ketamine is listed here, but actually the information on ketamine in geriatric patients is very much confusing, and we don't really have identified which patients benefit or have negative response. So these are action items for us, anesthesiologists, where we can optimize perioperative and intraoperative factors to minimize the risk for postoperative cognitive dysfunction and delirium. There's conflicting evidence and something we probably have to continue following up on. However, fluid status is the vascular tone is rigid, and there, you anticipate huge fluctuations during either general or regional anesthesia in blood pressure, in vasotone. It's very easy to overhydrate or under-resuscitate this patient cohort. And so far, we don't have an optimal monitor to estimate and identify normal volemia. So that makes it challenging. However, overhydration or underhydration, surely has an effect on, has an impact on neurological status. In the same token, meaning hemodynamics, intraoperative hypotension and hypertension, all of them have been linked to a higher risk for postoperative delirium. Cerebral autoregulation limits, depending on if your patient has pre-existing hypertension or is used to higher systolic pressures, also may be affected and shifted. So it may make sense to have a functional neurological status assessment. However, here there's conflicting evidence if that is beneficial or not when it comes to postoperative delirium prevention. Glucose control is, we need to have the intraoperative monitors, but with hyperglycemia, neurons are much more vulnerable for hypoxemia and underperfusion. And we all are aware of that hypoglycemia also diminishes neurological function and can cause neurological ischemia. The effect of hyperoxia in the intraoperative period also very controversial if that is more promoting postoperative cognitive dysfunction or not. So let's go back to another recommendation in this consensus statement when it comes to patients at risk for postoperative delirium. It has been recommended that identified surgical patients at high risk for postoperative delirium should be informed about their risk. A preoperative discussion with patient and family, in accordance with legal requirements for informed consent, gives patients opportunities to plan and implement shared decision-making strategies. We should encourage patients to think about who will make decisions when you cannot make them, when you're either incapacitated or when you just cannot verbalize or are too confused to make decisions. There should be a discussion of goal of care. Okay. What are the treatment options? Plan ahead, best to develop an advanced directive. In a perfect world, this should happen before decision is even made to proceed with surgery and should be initiated by the surgical team. However, sometimes it doesn't happen. The anesthesia team should confirm risk for postoperative delirium and plan with the patient and the family and discuss how this risk will impact the perioperative care plan. What's our perioperative treatment strategy? What are we doing to minimize the risk? Okay, what options do you have? Think about multimodal analgesia. Think about having family present postoperatively as early as possible to comfort the patient. The parallels to how we take care of children versus geriatric patients really, comes to mind. We do know that for pediatric anesthesia, the presence of the parents does reduce the distress and anxiety in our patient. So our geriatric patient might actually respond similar to that, meaning seeing a known person when they come out of anesthesia. The key part really is here communication. Communication with your patient and family cohort up in front. Discuss the limits and how to overcome communication difficulties in a patient with impaired communication abilities, vision or hearing or speech impairment. And also, you give the family a chance to discuss those concerns about hospitalization duration, postoperative care needs, the time requirement for them, so also the family can plan. There should not be any surprises. Well, kind of obvious for patients at risk for postoperative delirium, the experts recommended that we should develop a process to assess for postoperative delirium in older, high-risk patients. You won't get a fever if you don't take the temperature, kind of like approach. And due to the high risk of underdiagnosing this condition and severity, we should routinely use a daily assessment tool for delirium assessment in all elderly patients postoperatively. So here's a list of all those delirium assessment tools which have been validated. Some of them are more or less time demanding and are already used in your system or not. What has not been addressed in the expert meeting is what's the optimal timing for the screening process for postoperative delirium? Should it be done before discharge in the recovery room? Should it be done post-op day number 1 or 2? So these are surely areas of further investigation. The most commonly delirium assessment tool is the CAM method, and we will explore that further. So here are examples of the CAM or the confusion assessment method tool, as it can be either done in the regular floor or the CAM ICU. Usually performed by our nursing colleagues, but it goes pretty straightforward when you first look at the evidence of an acute change in mental status from patient baseline. Is there any abnormal behavior? And then, does the patient have any difficulties focusing, or is easily distracted, or has a hard time keeping track of what the communication is? In addition, there should be either presence of disorganized or incoherent thinking, or that the patient's level of consciousness is abnormal, either hyper-alert, lethargic, stuporous, etc., etc. As I like, postoperative delirium can come as hypoactive or hyperactive form. The flow of the confusion assessment method in the ICU is a little bit different. First, you look for altered mental status or fluctuating levels of consciousness. If that is positive, you screen the patient for inattention. Are they able to process commands? If that fails, you look at altered levels of consciousness and or the presence of disorganized thinking. So based on this, it's pretty easy to screen patients for postoperative delirium. The next big topic our expert group tackled was to make recommendations about strategies to reduce the delirium risk in a high-risk population. So first, they recommended that we should be using multi-component, non-pharmacological interventions for prevention of postoperative delirium in older, high-risk patients. This strong recommendation has been supported by moderate quality research, and it has been shown that bundled non-pharmacological interventions do reduce the incidence of postoperative delirium without any associated harm. Here in this graph, the non-pharmacological interventions have been summarized, which have shown to decrease the risk for postoperative delirium. Orienting communications, less using of physical restraints. Obviously, it needs to be balanced with the avoiding of self-harm and fall risk. But instead of restraining, you may be able to use sitters or family presence. And that has been associated with less postoperative delirium. The early return of hearing aids and eyeglasses as overcoming your hearing or visual impairments also here in the efforts to allow a patient to go back to normal, into a normal stimulation. Sleep enhancement, allowing our patients to return to a normal day or night cycle. Less care-related interruptions at night, as we know, like the checking on vital signs, monitors, giving medications at 2 a.m., or having other patient activity as they get admitted to the floor. All that, creates disturbance, interrupts sleep, and therefore promotes agitation in the delirium. We try to keep the room as quiet as possible when we want our patients to rest. We already have seen those strategies in the care areas where you're involved. For us anesthesiologists, the next topic makes perfect sense. You want good pain control. And with other means, and that can be not, on pharmacological, but also non-pharmacologically, that is possible. It sometimes is challenging to read your elderly patient well. When is a patient in pain, especially when they can't communicate well, as they may be intubated or unable to talk. So here, family presence and paying more attention to nonverbal clues may be helping to minimize these contributing factors to postoperative delirium. Nutritional support. Assist in encouraging eating and drinking. Elderly patients sometimes forget that. And food-wise, try to cater to the patient's preferences. Normal foods they like to eat, they enjoy eating. Also here, you can only heal if you support the nutrition and have, proteins and all essentials available. Medication review to avoid polypharmacy. Sometimes patients receiving medications with conflicting, antagonizing or, other drug interactions. And you also want probably pharmacy to review for optimal dosing. Early mobilization, trying to get our patient back to feel normal and go back to normal activities. Also here can be very helpful in decreasing delirium. All of those actions taken together as they work with each other and support each other are synergistic, may lead to shorter hospital stays and better outcomes. So what else can we do to reduce the postoperative delirium risk? Well, we like to give medications. Here, the experts recommend that we should minimize the medications to be known to have psychoactive side effects. As mentioned before and listed previously, medications with anticholinergic side effects should be avoided. Also avoid benzodiazepines, since they have been associated with more and lasting cognitive dysfunction in elderly patients. As mentioned previously, meperidine should be avoided either for shivering or for analgesia, since it is known to cause confusion. Ketamine, as I stated earlier, is controversial. It can cause psychosis, but it also may have beneficial impact in certain subpopulations of geriatric patients. So then, there are some areas of uncertainty when it comes to what can we do to reduce the risk for postoperative delirium. Is using a process EEG for anesthetic depth monitoring helpful? Here, the expert groups had a split opinion. So the statement is that there's insufficient evidence to make a recommendation. Several studies found that BIS-guided management did not decrease the incidence or severity or duration of postoperative delirium in older patients. Other studies showed that the processed EEG-BIS for less anesthesia depth and less burst suppression actually reduced the risk of postoperative delirium after surgery. So, supported by 5 experts out of the group, they felt that they needed to write a different opinion, meaning there is weak support that processed EEG BIS monitoring should be used and anesthesia depth should be titrated around above 45, and we should avoid levels of less than 20. The statement commented on more anesthesia areas when it came to reducing the risk for postoperative delirium. There's insufficient evidence to recommend a specific anesthesia technique or agents to reduce postoperative delirium risk. The rate of postoperative delirium is similar in elderly patients if they receive TIVA or volatile anesthetics, no preference. There's inconsistent evidence about volatile anesthetic depth associated with the risk for postoperative delirium. As I commented earlier, using BIS or not, it's unclear if this is beneficial or not. Since postoperative delirium has been observed in neuroaxial anesthesia and in general anesthesia, it really is unclear if sedation titration in the depth of sedation correlates with postoperative delirium. As said previously, it has not been found that neuroaxial or regional techniques are associated with less postoperative delirium based on the expert assessment. There is insufficient evidence to recommend a specific anesthesia technique. However, there are several randomized controlled trials ongoing, and hopefully more information will be available to enlighten us on this topic. One recommendation to reduce the postoperative delirium risk is kind of obvious for us: optimize postoperative pain control. There is an association between poor postoperative pain control and the development of postoperative delirium. Since opiate and other systemic analgesia may have psychoactive effects, it is advocated for a multimodal approach, including peripheral nerve blocks and epidural methods to control pain. Effective pain control decreases postoperative delirium. There's insufficient evidence if IV lidocaine or continuous intravenous ketamine infusion are beneficial. So how about giving medications prophylactically to reduce the risk for postoperative delirium? After reviewing the literature, the expert found there's insufficient evidence to recommend the administration of prophylactic medication. It has been shown that prophylactic haloperidol does not make a difference. Prophylactic dexmedetomidine did not make a difference. Intraoperative ketamine boluses did not make a difference. And also perioperative gabapentin did not make a difference when it came to development of postoperative delirium. That does not mean that those medications may be helpful in treating it, especially haloperidol and dexmedetomidine. It has been shown that some medications do make a difference when it comes to reducing postoperative delirium in patients who are sedated in the ICU. The expert group recommended the use of ICU protocols in sedation with dexmedetomidine for postoperative delirium prevention if elderly patients go into the ICU requiring postoperative ventilation. So in studies, dexmedetomidine has shown to have less postoperative delirium when compared to benzodiazepines, propofol, or morphine-based sedation. I want to conclude this presentation about postoperative delirium prevention with this graph out of the publication. Just documenting that to be successful, we all have to work together and really come up with a systematic, step-by-step approach to address this problem. Preoperatively identifying, first screening and identifying, and then also counseling and optimizing. Key part of the success. Interoperatively, there are things we can make things better. A lot of questions have not been really answered, but there are certain things we know will make a difference. And then post-operatively, also here it comes all together, we have to help that risk population, elderly patient, to recover and to go back to normal, to their normal life as early as possible. So they get back into their comfort zone and more or less get out of the hospital. So that means not only assessment, but also early intervention, pain control, minimizing medications, and all those non-pharmacological interventions I've described before. Overall, it's a team approach, and only if we're working all together with each other, we will be successful. And as we're getting more and more elderly patients as our patients, this is really an item of high importance. Thank you very much for your attention, and please feel free to contact me if you have any further questions.